The speaker, Elvena, is going to share her dog from Oklahoma. And Elvena has a multidisciplinary background in IT, life science, and business. Today, she is going to share with us her experience in CHSI, transforming rural healthcare with data, the challenge and problems implementing analytics in healthcare area. And
Yes, I can. Can you hear me?
Yes. Okay. Let's give her a warm applause.
All right. Hi, everyone. Thank you so much for joining me, and good morning to all of you in Taiwan. So I'm going to share with you a little bit about my organization and how we use health data to drive changes in rural healthcare. So a little bit about my background, in case you're not too familiar with me. I actually have a multidisciplinary background. I started out with a bachelor's in biochemistry with a minor in computer science. And then later on, I went to get a master's degree in biotechnology with specialization in bioinformatics. And then afterward, I went to get a second master's, this time in business administration, so an MBA. And if you look at my working experience, it kind of mirrors my educational background because I worked in a number of very, very different roles. So after getting my bachelor's degree, I started out as a web designer. And then when I got my master's in biotechnology, I jumped over to a biotechnology company to work as a bioinformatician. And then after that, after I got my MBA degree, I became a data integration technical lead at a data collection company. And now I'm a program manager at the Center for Health Systems Innovation. And in my current role, I'm in charge of managing the data analytics team at CHSI. I also support a lot of the data collaborators who work with us, and I also maintain the Health Facts database. I'll talk a little bit more about what the Health Facts database is later on, but essentially it is a clinical electronic health records database that is a foundation of a lot of our data projects. So before I continue, I wanted to share with all of you a little bit about what the health market is in the US, because I think it's very different from what you see in Taiwan and many other countries. And I think it's important to have that context because then you can understand how our organization fits into the picture, and then what are the problems we're trying to solve. So first off, the healthcare market in the US is very, very fragmented. Unlike Taiwan, we do not have a national insurance provider. Instead, we have a mix of what we call private and public insurance providers. And then doctors and hospitals, also called providers as well, will sign contracts with different insurers to negotiate prices. So your insurance coverage, which you generally obtain from your employer, dictates which doctors you can see. So it's a very different concept, unlike what you have in Taiwan, because in the US, you don't just go to any doctor you want. You have to go to a doctor that is in your insurance company network. So where it gets really, really interesting is that depending on where you live and who you work with, your insurance coverage will actually vary. Because in some large cities, there are large employers who have who have all the negotiating power. So if you happen to work with these companies, you're going to get very good benefits, very good coverage, and very good rates. In other places, though, certain hospitals or health systems possess all the bargaining power. So what happens is if you go to any doctor or any clinic or any hospital, they will all pretty much belong to the same health system. And yet in other places, the insurance company is very dominant. And you can actually see this even at the state level. So over here, I have a graphic on the right-hand side that shows consolidation of market by insurance company. The states that tend to be red means that one or two insurance companies dominate the entire market. So when it comes to choosing which insurance company you want, you don't have a whole lot of choice. The states that are gray or black tend to have a little bit more choice for you, so you can get better rates. So it's very interesting because the interplay between insurance provider, employer, and health system ends up dictating the size of your provider network, the prices you end up paying, and your overall coverage. So this is a very, very different concept than what you have in Taiwan and many other countries. We also have a lot of problems within the US healthcare system. You're often going to hear people say that we spend almost 18% of our gross domestic product, or GDP, on healthcare. And that's a lot more than any other industrialized nation. So when you look at cost in terms of the dollars we spend for each person each year, in terms of the prices we pay for medications, and in terms of the prices that we pay for procedures and treatment, healthcare costs a lot in the US. But what's really interesting is that even though it's much more costly, health outcomes in the US are not better. And in fact, the really odd thing is that life expectancy in the US is actually going down. It is decreasing. And there are also two major trends that are affecting the future of healthcare in the US. First is that our population is aging. We have a population of people called the baby boomers. They're starting to get to the age where they are getting old and retiring. And with that, that's expected to translate to higher demand for healthcare services. The second other trend that we have is that we currently face a shortage in doctors. And many of these doctors also belong to the same generation of baby boomers. So they are also getting to the point where they're getting ready to retire. And as a result, we're going to have a much smaller number of doctors that are available to serve our population. So consequently, if you look at healthcare costs in the US, we're expecting the costs to grow unless we make very, very large changes to our system. So as a result, you'll hear a lot of focus and a lot of attention about boosting the quality of care, or improving outcomes, or even reducing costs. So now that you kind of have a context for some of the problems in the US healthcare market and how it's structured, let me talk about our organization and how we fit in. So my organization is the Center for Health Systems Innovation, also known as CHSI. We were founded in 2014, so we're a relatively young organization, about 5 years. We exist as a joint center between the School of Business and the medical school at Oklahoma State University. So that means we sit right at the intersection of healthcare and business. Unlike a lot of academic centers, we also have a very unique focus on implementation and not just research. So if you actually look at our vision and mission, our vision is to transform rural and Native American health. And we want to do that through the implementation of innovative care delivery and IT solutions. And we're actually structured to support this dual purpose of innovation and implementation. On the innovation side, we have the Institute for Rural Care Delivery. This team will actually go out to work with rural hospitals and clinics to try to identify what are the largest problems they face, and then from there, they're trying to develop ways to help them improve their processes or become more efficient. My team, we are the Institute for Predictive Medicine. And what we do is we try to develop algorithms and tools and apps to try to improve patient outcomes. And these begin to be deployed in rural hospitals and clinics. On the implementation side, we have 3 very different networks that we actually work with. One is the Health Access Network. They provide direct care to patients. We also have RockNet, which consists of a number of smaller hospitals, rural hospitals and clinics all across the state of Oklahoma. And then we also have the Rural Health Network. And these involve larger hospitals and systems within Oklahoma. So 3 very different networks of hospitals, patients, and clinics that are willing to implement or test a lot of our ideas, and that allow us to try different ideas at different levels of healthcare. So you might be wondering, why are we so interested in rural and Native American health? Because after all, if you're doing innovation, doesn't it make more sense to go to a large city where you have a lot of people and is much more concentrated? But if you think about it, there are a lot of significant challenges in rural healthcare. You can actually even think of it as a supply and demand problem. So on the demand side, you have a very high incidence of what you call chronic conditions. That means diabetes, obesity, heart problems, very, very common in rural populations. Patients also tend to be a lot older and poorer, and then they're also uninsured or underinsured, meaning they either don't have insurance or they don't have enough insurance to cover their healthcare needs. And then on the supply side, there really aren't a whole lot of doctors in rural areas, so not enough doctors to serve the rural population. On top of that, it's very difficult for rural patients to access what we call specialists. So specialists are like the eye doctor, the heart doctor, specialists who's focused in a particular part of the human body. And then on top of that, there's a lack of access to technology layers. And last but not least, a lot of rural hospitals and clinics are also closing down in the US because they are not able to be profitable. So what that means for a lot of these patients is if they happen to need emergency care, they're going to have to go to the next closest hospital, which might be an hour or two away. And we know that's not a good thing when it comes to an emergency. So there are a lot of challenges in the health. And what we found is that many of these challenges are shared by Native Americans who actually live in Oklahoma. So hence, we decided to focus on rural and Native Americans. But even more importantly, a lot of these challenges are also shared by many international communities. So we figured if we can develop innovations that serve rural and Native American populations, and if we can test and implement them, then we can take it out to communities all around the world to improve the health of patients. So with that, hopefully you have a much better understanding for our group. And now I'm going to drill down into my team specifically, predictive medicine. So earlier I had talked about a database that we use that's called Cerner Health Facts. So this database was given to us by Cerner Corporation. If you're not too familiar with Cerner, they are an electronic health records system provider. So they deploy their system at a lot of hospitals and clinics across the entirety of the US. And then they collect this data and then they let us use it for research. So if you look at Health Facts, it covers patients across the entirety of the US for a period of 16 years. Now, if you are in a country with an integrated health system, that might not seem like such a big deal. But here in the US, our healthcare system is very fragmented. Hospitals do not share patient information with each other. We don't have a national system for storing health information. So being able to get our hands on such a huge information repository is a very big thing for us, and it's a very valuable resource for doing research. This database covers information on 63 million patients with over 489 million visits. It's also what we call de-identified HIPAA-compliant data. So de-identification means that we took out a lot of personally identified information. And this is important because in the US, we have very strict laws governing privacy of patient data. So if this data were not de-identified, that means that every time we want to do research with it, we would have to go through an IRB process, an institutional review board process, which easily adds months and months of time before you can even start a project. So the fact that this data has been made de-identified and HIPAA compliant means that now if we want to start a project, we can do so. We don't have to wait to go through an IRB process. And it makes it a lot easier for us to support students, researchers, and collaborators who want to work with us. The data set is also very, very comprehensive. So inside this data set, you're going to find medication data, you're going to find lab results, you're going to find information on what we call vital signs. So that's things like heart rate, pulse, breathing, temperature, respiratory rate. You're going to find information about the visit itself. So what kind of hospital the patient went to, some of the demographics of the patient, and where they were discharged to afterward. And then you're going to find billing data in the form of procedure codes and diagnosis codes. And the beautiful thing about all this information is that it's timestamped. So from the moment that a patient first enters a hospital or a clinic, to when they get a lab test done, and then that result is interpreted, to when a vital sign is recorded, to when they are administered a medication or undergo a procedure, to when they finally leave that hospital or clinic. We can literally trace the path of a patient throughout the entirety of their visit. So what exactly is electronic health record data? You can think of it as every time you go and see the doctor, or you go and fill a medication, or you go and get a lab test done, or even a scan. All of that information is collected in this database. And the really beautiful thing about this database is now you can slice it and dice it to serve a number of very, very different needs for different people. So for instance, if you are a doctor, you probably want to pull information on a particular patient and all of their history, because it helps you deliver what we call better point of care. On the other hand, if you are a hospital administrator, you want to take a cross-cut of the data because now you can do statistics on it to try to understand if you are meeting guidelines, if you are efficient, and what are the trends within the patient populations. If, on the other hand, you are like me and you do research, you actually want to pull out different groups of patients and some of their history, because you want to try to understand how they respond differently to treatments, and what are the different outcomes that are associated with them. So as you can see, electronic health record poses a lot of potential for research and a lot of promise for really changing the way that healthcare is done. So just to give you an example, I'm going to go through a couple of the different projects that we've done in healthcare. So one of the very first projects we did was to use the health facts database to compare drug treatments. So in this case, we were looking at a drug that's called digoxin, which is actually used to treat a heart condition called atrial fibrillation. If you're not too familiar with atrial fibrillation, it's basically when your heart valve doesn't close properly. Now, digoxin is a very, very old drug. It's been on the market for a very long time. It even predates our Food and Drug Administration. So when the FDA, the Food and Drug Administration, was established, they just grandfathered digoxin in. So unlike a lot of the other newer drugs, the digoxin never went through any kind of clinical trials. What's interesting about this drug is that you go and ask any cardiologist or heart doctor what they think about the drug. You're going to get very, very mixed opinions. Some cardiologists will say that digoxin is a great drug, no problem. Other doctors are going to say digoxin is a terrible drug. It seems to have very bad effects for their patients. So what exactly is the truth here? We decided that since we're sitting on top of all of this data, why don't we go find out? So we went ahead and pulled up 77,000 patients who had a diagnosis of atrial fibrillation. And then we looked at their mortality or death rate as an outcome of treatment. So we started out initially by pulling all atrial fibrillation patients and then comparing mortality by race. So here you have Hispanic, Caucasian, Native American, Asian, and African American. This particular graph is really not that interesting. You will see that in general, African Americans tend to have the highest mortality rates. But that could simply be due to a number of other factors, such as genetics or social or even economic factors. We next started to break down these patients based on whether they took digoxin or cardizem, which is another drug that is used to treat atrial fibrillation and actually went through clinical trial. And what you're going to see is that in most of these populations, it looks like mortality goes up with digoxin. And these red bars are just the reference from the previous graph up here at the top. We also broke it down by gender. So here's females, here's males, and once again, we kept it broken down by whether a patient was on digoxin or cardizem. And now you start to see some more differences emerge. So when you come back to the question of why cardiologists are disagreeing about the drug, you actually start to see the reasons why. Because if you're a cardiologist in the US and your primary patient population are African American females, you're going to feel that yes, digoxin does have a much higher mortality rate than cardizem, much worse impact. On the other hand, if you were a cardiologist and you were primarily treating Asian males, you're probably not going to find the difference that's significant. So you're going to feel that digoxin and cardizem and other drugs are about the same. So even through a very simple project such as this, analysis, we were able to discover how different populations respond differently to different drugs. And that is the power of electronic health record data, because now with this kind of information, we can help physicians make much better decisions on what kinds of drugs or treatments to give various populations of patients to avoid some of the negative outcomes. Another project that we did was basically predicting adverse outcomes. So in this case, we were looking at a disease called diabetic retinopathy. If you're not too familiar with diabetes, basically there's a very high risk that you're going to go blind eventually. And that is called diabetic retinopathy. What's interesting about diabetic retinopathy is that in its very, very early stages, there's no symptoms associated with it. And the only way that it is detected is through an annual eye dilation exam. Now, where it gets very interesting is that once you detect it, you can actually treat it through a laser surgery. The laser surgery will stop the disease from progressing, but it will not restore vision that is lost. So once you lose the vision, there's not much that surgery can do for you. So what's interesting about this disease is that even though the eye dilation exam has been shown to be extraordinarily effective at diagnosing the disease, a lot of patients actually do not listen to the advice of their doctors to go get this eye exam done. So what happens is they wait until they start losing their vision, and then they go and let the doctor know. And by that time, there's not much that the doctor can do. And the reason for the low compliance is because what happens is once you get your eyes dilated, there's a period of about 3 or 4 hours where you can't drive and you can't be exposed to bright light. So for many patients, they think that when the doctor tells them to go get the exam done, they think that, hey, I see fine, why do I need to take a day off work to do this? So that's the challenge here. What we decided was, since we were sitting on top of all this data, what if we can go data mining and go through the health facts data and try to identify if there are certain biomarkers that we could use to predict what patients are in early stages of diabetic retinopathy. Because a blood test is much easier to do than an eye dilation exam. And for patients in rural areas, it's also much more accessible. Because to do an eye dilation exam, you have to go see a specialist. So we went ahead and pulled information up on 2 million patients, and we evaluated 1.5 billion variables. We put it through machine learning, and we identified 14 variables that could be used to predict whether a patient was at risk of early stages of diabetic retinopathy or not. What is really fascinating is out of these 14 variables, 10 of them are completely brand new, meaning 10 of them, if you go through literature, if you go ask any doctor, no one has any awareness that these were ever linked to diabetic retinopathy. And this is really the power of what we call machine learning and artificial intelligence to discover new patterns and new trends in the data. And of course, because we are very focused on implementation, we don't want to stop there. In fact, our eventual moonshot, our ultimate goal, is to create a single tool that can non-invasively monitor all diabetic complications. Because can you imagine what putting such a tool in the hands of a doctor would do? Because now, rather than a doctor telling each and every patient every single year to go get that annual eye exam done, now they can target their efforts on those patients who are high risk and try to get them to go through the eye exam as well as to get some of the follow-up care that they need. So another use case that we have is using the health data to augment what we call discharge planning. So hospital readmissions is actually a very huge issue that a lot of hospitals face. If you don't know what readmission is, basically readmission is defined as when a hospital discharges you or when a hospital lets you go home, they tell you that you're great, and then you come back because the same problem has occurred. So in the US, there actually are very high penalties that hospitals face. If they let a patient go and a patient comes back within 30 days, we call it the 30-day readmission rate. And when you look at readmission, one of the disease categories that has a pretty high readmission rate is what we call hip fracture. So hip fracture is basically breaking the bones in your hip, and it tends to affect older Americans. Now, with the population aging, hip fracture is becoming a very serious thing that we're worrying about. So again, just like diabetic retinopathy, we decided, since we have a lot of data on hip fracture patients, why don't we use the data to identify key factors that we can use, just group and stratify, and identify the patients who are likely to come back or who need to go, who should not go home. And hopefully with this, we can develop a readmission score that can help hospitals, nurses, even patients plan where patients need to be going after the hospital. And some of the very early factors we've discovered as we were doing some of the analysis were that patients who tended to have the highest risk tended to be male, they tended to be older than the age of 75, they tended to have more than one comorbidity or multiple diseases is what that means. And they also tended to have a longer length of stay, so over 5 days in the hospital. And the beautiful thing is that with the power of machine learning, again, we hope to be able to identify novel and important risk factors. A lot of the machine learning algorithms tend to be a lot more accurate than existing systems, which may be built through logistic regression or even through doctors just noticing some common factors. And with some of the selection methodologies that we've developed, we're going to try to limit a lot of these machine learning models to incorporate fewer variables so that they're easier to implement in a rural setting. And again, just as in the case of diabetic retinopathy, our ultimate goal is this whole suite of discharge planning tools that can be implemented in a rural setting to really help those rural hospitals and clinics discharge patients at the right time to the right place. So hopefully that gives you a pretty good view of some of the different things that you can do with EHR data. I want to shift topics a little bit and talk about the challenges to implementing analytics at CHSI in our journey, because I think that's a very, very interesting story to tell. So initially when we first started, we really had to overcome a number of different challenges, and I like to group them into 5 major categories: technology, access and tracking, data cleaning, knowledge management, and just the overall challenges of working with a huge data set. So the first area of challenge deals with technology. Basically, the questions here were, how do you store and manage data? Because remember, this is a very large data set. We're talking 63 million patients over 16 years worth of data. And then secondly, what tools are best suited for analysis and predictive modeling? So to kind of give all of you a bit of a walk or a view back in time, about 3.5 years ago when I first started, the data was stored on a Microsoft SQL server, but it took 2 days to pull data out of that database, so it wasn't very fast or efficient. On top of that, our team consisted mostly of students who primarily use a program called SAS. Oklahoma State University has a very good relationship with a software company called SAS, so a lot of students who are trained to use SAS. But SAS is also a very expensive software and not very suitable for operation in rural areas. So that's why we were curious to know if there were other tools that were better. So we started out by tackling the technology issues, and the first was really trying to get the database resolved so that we can pull data out more efficiently. So I went in and I resolved a lot of inconsistencies and duplicates within the data. I verified the data types and reloaded all the data again. And then I added some code to speed up and simplify the queries. And the net result of that was overall, we were able to reduce our querying time, the time it takes to pull data, from over 2 days to less than an hour in these cases. Once that problem was solved, the next thing I tried to do was we started to conduct a technology assessment to try to identify what softwares were more suitable for our needs. So we looked at some of the most popular analytics softwares. And this picture on the right shows some of the common softwares that we looked at. And we really found that no software was perfect for all situations. So our final solution was to use a combination of SQL, because SQL actually can be used to run very quick reports in conjunction with different analytics softwares to analyze data. So once this problem was taken care of, came the next area of challenge, dealing with access and tracking. So the primary questions here were, who should be able to access this data? And how should we track and manage that access? And again, to kind of give you a bit of perspective, 3.5 years ago when I first joined, we pretty much gave students, researchers, anybody who wanted to work with the data direct access. Not a very good idea, because the problem was there were only a limited number of connections allowed to the server at one time. So if too many people tried to use the server, other people would have to wait for someone to finish first. We also didn't have a whole lot of control over what queries or what data requests were being made. So if someone launched something very, very data and memory intensive, everyone would have to wait until that request finished. We also supported every single data request that we received. So once we got too many people who wanted data, we couldn't keep up with every request. And then outside of the confidentiality agreement, so a confidentiality agreement basically means that you agree that this data is confidential, so you won't share it with anybody else. So outside of this confidentiality agreement that Oklahoma State University provided, we didn't have any other agreements or documentation. So we didn't really know what people were doing. We didn't know how long they needed access to the data. We didn't make any requirements that if they published, they made sure to give us the appropriate credit. We didn't even know what they were going to publish. So we used a number of methodologies to solve that. So first off, we centralized the data access onto the program manager. That was essentially me. Wonderful thing was, in addition to allowing me to have more control over what queries were being run on the server and when, so if somebody wanted to do something data intensive or memory intensive, I could save that for the evening hours. But another really great benefit was, over time, as I wrote more and more queries, I became a lot more familiar with the data. So I could write much more advanced queries and much more powerful reports. The next thing we also did was we developed a process for reviewing new data requests. So it used to be that whenever anyone came up to us asking for data, we would say, great. We changed that to a monthly review timeline, so that every month we would get together and review the different data requests that we got. And we could choose to support those projects that we felt were in alignment with our mission and that we had the resources to support. We also reworked the legal documents to include some of the additional requirements that we wanted to enforce. And then last but not least, very importantly, we implemented a project tracking system, which allows us to track which projects we're supporting. And we also started to document the purpose of the project, the length of the support period, who were the individuals involved, as well as what publications were in progress. And the wonderful thing about all of this now, all these changes, is that we could start to improve our ability to track projects. We were able to provide much higher quality support to the projects that we were keeping, and then avoid confusion. So now, if you ask me, what are the projects that we are running right now, I can pretty much pull up the list and tell you. So with that issue resolved, the next major challenge was data cleaning. The electronic health record data actually is not clean data. You do not pull it out and just start analyzing it right away. There's a lot of data cleaning that needs to be done. So our initial questions were, well, how do you handle all the inconsistencies in the data? How do you normalize it? And then really the question that a lot of people always want to know is, what is everyone else doing? Again, 3.5 years ago, just to give you that perspective, there were some publications that talked about how do you analyze EHR data, but very, very few publications talked about how do you really clean the data so that you can analyze it. So the end result was that on our team, everybody was figuring out their own way to clean data, and people came up with different solutions to address different problems, but we really did not have a consensus. So to solve that, we used a number of different strategies. We started to shift our team away from students and really more to permanent hires to try to improve the knowledge retention, because students, they tend to come, they tend to go. But with permanent hires now, we can build that knowledge over several different years. The other thing was that we also started to hold what we call monthly research meetings, as well as weekly book clubs, to encourage team members to share and exchange knowledge with each other, to talk about some of the problems they ran into, some of the solutions they used, and then we could start to have those discussions on whether that solution made sense or not, or even how to improve that solution. We also encouraged all researchers to broaden their research scope every time we started on a project. So it used to be that anytime we started a new project, we would go and pull up literature on other EHR analysis. But we started to encourage team members to actually look more broadly and look at medical literature, to try to understand what are the current problems in that disease category, what are the gold standards for treatment, what are the known factors that increase risk, and then how do people define the patient population? So that way we had a much more better understanding of how the algorithms or the tools or the models that we develop, what is the contribution that we are making to the medical field? In cases where we couldn't figure out how to solve the problem, we also turned to subject matter experts. So we would reach out to medical people, we would reach out to hospital administrators, we would reach out to people who provided patient care to try to understand why some of the inconsistencies in the data are the way they are, what are some of the problems, and what are some of the reasons why this data looks the way it does. And then the last, most important thing that I really cannot emphasize enough to all of you. No one can ever tell you exactly how to do everything, right? So you really have to go out and do trial and error. That means you're going to have to go do it, even though you don't know the complete answer. You share it with other people, you get the feedback, whether it's good or bad, and then you refine your methodologies, and you keep doing it over and over again. And that's how, over time, we were able to start to standardize some of our data pre-processing approaches. And that leads me to the next problem, next challenge area, knowledge management. So with knowledge management, our questions here came down to, how do you ensure that analytical and data cleaning processes are consistent between team members? Because I can assure you that if you tell two people the exact same thing, they're each going to go off on their own and do it differently. Another question, how do you provide seamless knowledge transfer? So anytime someone joins a team, how do they pick up all this information quickly? Last but not least, what are best practices and guidelines when it comes to doing health analytics on EHR data? So 3.5 years ago, again, just so you had that perspective, everyone on the team was still new, even me, we were all learning. And people would develop and run their own code for their own projects. And they would save it on their computers. We didn't have a common repository to store knowledge, algorithms, or code. So what we did was we used a number of different approaches. So first, we developed a couple of tools to address some of the common data cleaning steps that we did. We also set up a code repository. And we encouraged team members to put their code in there and also to use each other's code. And if they found a mistake, a bug, or something that could be improved on, definitely make it better. Because that way, rather than people spending their energy rewriting the same code over and over again, we could now really improve our existing code. We also set up a guideline, we call it the CHSI analytics process, or CAP, for all of our data analytics projects. So we basically break all data projects into 4 different stages. the scoping of the project, the descriptive analytics, predictive modeling, and the final report or implementable solution. And we list what are the expected steps and outputs that we want to see. Now, this is a lot of things for people to process, so our next question was, well, how do you bring all of this together? And what we started to realize was that for some of the projects, maybe like a drug analysis project, regardless of which drugs you're looking at, the sequence of cleaning steps are almost always the same. But those steps are very different from the steps you might use in a readmission project. So we came up with the idea of templates. And the idea with these templates is that we could implement the CAP process as a foundation. And we would link the tools and the code together to support different project types. And it would generate publication-ready output and standardize the analysis among our users. And we currently are working on 2 different templates, one that's for readmission, and that first part is completed up to the descriptive analysis, and then the second one for doing comparative drug analysis. And of course, obviously, as we finish these 2, we're going to have more templates coming later. All right, final area of challenge, the overall challenges of working with a huge data set. So the question here is, how do you clean, analyze, and run predictive models over large data sets without running into memory issues? Because I know for a lot of people, they get very excited when they see big data. They want to get their hands on all the data they can. But as it turns out, for a lot of researchers, they do not have the computing capability to handle all that data. So we came up with a couple of different solutions. So we actually encourage people who first come to us, when they say they want all the data, we tell them, let's actually randomly select a smaller data subset and use it for initial data preparation and analysis. And if they find something interesting, then we can move on to the OSU high-performance computer cluster and repeat the same analysis with a larger set of data. Of course, the other option is we can also move onto the cloud because Amazon Web Services, Google, Microsoft Azure, they all have their own cloud computing solutions. But really the thing to keep in mind is that each solution offers a balance between cost and speed. There really is no perfect solution. So with that, I hope that you all found this presentation very interesting and very relevant to you. Hopefully you all learned something, but there's a couple of messages that I want you to take home at the end of the day. One is that you have data coming from and going everywhere, and healthcare is really no exception. And with data, especially big data, you can actually get a lot of great insights that can actually be used to drive innovation and allow us to create all these clinical decision tools to support patient outcomes and care delivery. With the Cerner Health Facts database, it's actually a golden opportunity for our center to lead the field in health data analytics. And then we definitely are open to collaborations to support our mission, whether that be in terms of expanding some of our existing health analytics programs, or co-developing new tools, or even sharing capabilities, knowledge, and resources. And if you would like to learn more about us, you can definitely visit our website, or if you'd like to reach out and contact me, I have my email and link here. Any questions from anyone in the audience?
Elvena, can you check on the Slido questions? Can you see all the list?
Yeah. Are they okay? So I just need to start answering them.
Yeah, you can choose the first 2 one, and it's quite similar. It's all talk about the diabetic case you have mentioned, about how did you filter 14 features from 1.5B features and what techniques used here. And the second one is a little similar, that you found the 14 new feature, and how can you be sure that it's not the cofactor to cause it.
Okay. So the first question, actually that was done by our PhD student. It wasn't done by me, but what he did was to use something that's called an ensemble method. He used random forest. So in the random forest, and I'm sorry for those of you who are not technical, but you can think of it as a lot of decisions. So once you run the random forest, you can actually run what we call a variable importance ranking. And there are algorithms that can do that. based on the random forest to identify and rank variables by importance. So the student who did that, he used that to identify the top, I think he started out with the top 20 or 25 variables, then he would restrict and decrease the number of the list, and then rerun the algorithms again and again until he got something that he felt was a minimal set of variables and we could still maintain the same accuracy. So hopefully I hope that answers the question, and if it doesn't, I guess you can definitely feel free to comment more in the slide. The second question, so how can you be sure that newly discovered features have causality with disease? So one of the things I'm going to emphasize to you right now, machine learning does not pick up causality. It picks up something we call correlation. And a lot of people actually make the mistake of assuming that machine learning will try to identify causes. It does not. It identifies patterns and trends that can be used that happen to correlate with the outcome. So for us in a lot of cases, just to make sure we're not picking up something that totally does not make sense, we actually will consult with medical professionals just to kind of get their opinion on what they're thinking about. And that's kind of how we identify that these are some of the cofactors that make sense to include in an algorithm. So I hope that answers that question. Are there any other questions?
The third one is asking about, do you use more the transparent machine learning algorithms, rule-based, to make your prediction more explainable?
So, let me think. We actually use so the strategy that we use right now is we try to use a combination of different algorithms. So we will use logistic regression because a lot of doctors and medical professionals actually don't like anything more complex. And we've had cases where we try to take more complex things like a random forest or decision support vector machine neural network. Doctors don't tend to like that because they don't understand how that algorithm works. So what we will do a lot of times is we will use the combination approach. So we will use a logistic regression model, we'll develop a decision tree model, then we'll develop what we call kind of a more advanced model, whether that be a random forest or a neural network. So we kind of use different algorithms. At the end, what we try to do is, because we're very focused on implementation and making it easy for hospitals and clinics to implement. So if you throw a neural network at a hospital or clinic, it may not be as easy for them to implement. So we will develop a multiple number of models, we'll compare their accuracy. If the logistic regression or the decision tree kind of comes close to the more advanced models, then we'll go with those. Should I continue going through the slide questions or?
Yeah, there's like 10 of the questions there, but we kind of like left like 5 to 10 minutes, so you can choose like 3 of them and share what you think about these questions.
Okay. All right, so the next one, what training do the students and hires working for the center have? So this actually is very interesting because data science itself is a very, very new field. And we kind of find that people come from a lot of different backgrounds. Now, our center specifically, we end up hiring a lot of people from OSU, Oklahoma State University, because Oklahoma State University happens to have what they call a master's in information science. And they also have an industrial engineering program. And a lot of the students there, they are trained to do data analytics, they are trained to do machine learning, and in the case of industrial engineers, they are also trained to do network optimization. But when I actually look at people who do become data scientists, I see a lot of different varieties. I mean, you can even look at me. I don't have a formal data science degree or industrial engineering or that kind. Instead, my background just kind of evolved from what we call informatics. And later on, when I came and joined the team, I actually took out a book and started teaching myself how to do data analytics and machine learning. So if you look at other people and their background, I've seen people with physics degrees, like PhDs in physics, go and become data scientists. I've seen people who are just the statistical backgrounds. They also can go on and become data scientists. So I think there's a lot of different backgrounds that actually you can come from to enter the field of data science. All right, so let me type take a look at these other questions. Okay, so the next question is, how do you and your organization deal with situations where your experimental results conflict with experimental outcomes released by other sources? Surprisingly or not, actually that's very common. In fact, if you actually do literature review, you're going to see a lot of different data sources, and they all are going to say different things. And I don't know if you guys are even familiar with the recent studies about eggs, right? Is it good to eat eggs? Is it healthy to eat eggs or not? People keep seeming to want to change their mind on that. And we see the exact same thing with a lot of health data research, even on EHR data. So a lot of that kind of boils down to how you select your patient population and then some of the cleaning algorithms you use. And that's why going through the peer review process is so important. It's why after we develop models, we have to go through a trial or validation process with actual patients. Do we still have more time for questions, or are we, should I stop now?
We still have 5 minutes, and you can.
Oh, we still.
Yeah, you can choose one, or is there anyone want to ask questions in person? If Elvena haven't choose your questions， 就是刚刚 Elvena 还没选到问题，但你现在在上面很想问，但他没被投到前面，想要直接现场举手发问也可以，可以用中文，我翻，有吗？就是Elvena, you can choose the next question, and I will open to the audience for one more too. So we have 2 questions that 有人想要直接举手发问的吗？对，看到你跃跃欲试。If you can use English.
Hi, just a quick question, I think. Actually, I was pretty stunned by the number of variables that turned into 14 variables. It was actually like, I don't know, 15 billions or trillions. And so was that much kind of variables in the data set? That's just my quick question. Yeah, because it's hard for me to...
I'm sorry. Yeah, it's kind of breaking up, but can you repeat it one more time?
Okay. Actually, I also wrote it on Slido. It's like the question about the number of variables that turn into 14, because that's really a whole lot number of variables, and I'm curious, was that really that much different kind of variables in the health data set?
Yeah, the student who did that, actually I was using another person's slide. Those are, so when you look at the variables themselves, right, those are actually like categories of data, but the 1.5 billion, the 1.5 billion is actually individual data points that we have in the data set. So you kind of think of it, multiply each patient by the number of variables, and you have a total of 1.5 billion data points that we're working with. So that's not actually like variables in terms of number of different variables. It's actually just data points.
Okay. Okay, then maybe Elvena, you can choose the last question you want to answer.
Yeah, sure. So I'll just answer the next one I see. What language do you prefer when doing analysis, R or Python? This is actually very interesting. When we first started, everybody was on SAS because that's what a lot of the students were trained on, and I was probably the only one who had I was totally clueless about SAS. But over time, we eventually shifted towards R because I think there's a lot of packages that are written in R. But we found that actually probably a combination of R and Python works much better because Python is very powerful, has a lot of good tools for cleaning the data. And then once the data is all cleaned up, then you can easily bring it into R and run your analytical packages. But having said that, there are some of the students on our team, particularly the statisticians and even a medical student who's doing data analytics with us. They actually prefer things like, there's a software that's called JMP, JMP. JMP is developed by the company SAS, but it's targeted for biological scientists who don't know how to write code. So that's the preference of the medical student. And then the statisticians that tend to prefer things like, I think it was Strata or SPSS, I forget which one it was, but we have a lot of variety in software that we use.
Okay. So thanks, Elvena, for sharing your talk. And let's give Elvena a warm applause. Okay, so there are more talks to be continued in the following sessions, and we will have a 10 minutes